what is the minimum amount of care? You give me a problem I need to solve using healthcare. What is the minimum amount of care that solves that problem for you? So that's my clinical flaw.
Ready to go. Hello, everyone, and welcome to the Bedsides and Boardroom podcast, where we speak about the intersection between business and medicine. Today, we're going to be speaking about remote and extreme medicine with Nicholas Dillon. Nicholas, welcome to the podcast.
Thank you, Nathan. Pleasure to be here. Thank you for asking me to get involved.
It's great to have you here. Just as an introduction to our listeners, can you give us an idea of what you've been involved with in your career?
Yeah, sure. So I've been very sort of privileged and lucky in my sort of career to have quite a diverse exposure to healthcare systems around the world. So for about 20 odd years, I've effectively been very much focused on sort of complex environment, what would be termed as sort of remote healthcare. From an early stage when I left the military all the way up to sort of my present position now. My initial exposure was working as a provider for expeditions, remote healthcare industries such as the oil rigs, oil and gas sector, exploration sector, civilian expeditions, races, all that sort of stuff. I was initially sort of trained as a paramedic, pre-hospital specialist, backing from patients into more systems development, focusing on systems care. Worked alongside delivering services for United Nations, for military organisations within private sector, all the way up to providing as a chief operating officer for a Dubai-based private-public partnership working in the healthcare sector, and now as director of sort of healthcare delivery for another organisation that's currently delivering traditional hospital care but in remote environments in an area in Micronesia as well.
You've had a nice exposure in your career to being a clinician, all the way up to planning healthcare systems and how they are integrated. How has that been, all the way from clinician to the far side?
It's a nice route to have come, and especially coming from, and we'll cover it later on, but within remote environments, certainly clinics where I was working, where you'd be in one container or one oil rig and you're it. So your clinical scope tends to be quite expanded. And so that's backed up with education. So I'm a certified, board certified flight paramedic, critical care paramedic, master's advanced practice, postgrad emergency care, UK Reg paramedic, also an MBA. So I had quite a broad sort of exposure to that pieces, but I'd done every job. So everything from having to clean my own clinic, do my weekly drug counts, take x-rays, work out how the generator moves, run benchtop labs sort of by myself and working that out, all the way up to designing quite broad and robust sort of multi-million dollar sort of systems. The hands-on experience allows me to talk to various people. For example, I was just visiting one of the hospitals where I was there as I'm sort of the med director, and I was also part of the code team pushing chest, because I'm still ACLS qualified. So it allows you to have a granular level understanding of what needs to happen. I might not be the expert in everything, but I can speak to a lot of things and as sort of generalist. So I've been very lucky, and it certainly informed my way of management that, I've been up at whatever in the morning at the end of a 12-hour shift trying to cannulate a 4-year-old. I understand the reality of the challenges that the people face on the ground, and that's what I bring into sort of healthcare leadership and the realities of healthcare leadership sort of at a more senior level. So it's certainly served me well, particularly sitting in boardrooms, having that hands-on experience where you might be the only person who's ever done that. So you can certainly advocate for the realities of the ground at that level, which I think has created sort of a very much more sort of well-founded approach, I think, to developing systems at some more senior levels.
I think that's so important to have that clinical experience that now goes into the way that you manage, because it's quite easy to have this like umbrella understanding of how an organization works without knowing what actually happens on the ground. But just for our listeners to understand what the topic is of what we're going to speak about today, remote medicine and extreme medicine. Can you just give us a high-level definition of what is remote medicine and what is extreme medicine?
So I define it by its complex environment. My issue with the two terms is remote tends to create a geographical constraint. So yeah, so you can be it can be a constraint to doing good medicine. It's a logistical, geographical, temporal constraint in remote, but it tends to make you feel as though you should be out in the middle of nowhere where it's just you and your dog and that's it. Whereas there's a lot of places where you might be very well served, you're not remote, but be it political or conflict is in the way. There's a political sort of piece that's going on. Or there could be a logistical piece. So I could be logistically remote, but temporarily, if you're sitting in the back of an ambulance or sitting on a helipad somewhere and you don't have the equipment you require, that's the complexity of it. To me, with the term of extreme medicine, medicine's medicine. It gives you a bit too much freedom to operate on the extremes of medicine. We're not doing extreme medicine. We're doing good medicine. And that should always be the aim, that it's normal medicine that we're trying to achieve. The same healthcare, same best practice rules apply. And I think that there's a danger of the use of term of extreme medicine in some instances. Now, not all the time, and it's done in the intent, but we're not doing extreme medicine. We're trying to do good medicine in complex places. There are more complexity of challenges than you would normally find within a traditional healthcare system. However, we're still trying to achieve the same old goals. It's just in a slightly more difficult environment for various means.
Yeah, and I think it's not actually outside of medicine because these challenges that we have are occurring every day. There's resource limiting factors. There is logistical issues. So it's just that these are happening in a place that is quite a bit more difficult than you would normally
I
have.
mean, yeah, and things can change, so the environment can get more complex. So I've been talking to people who have had to do what we would term sort of remote medicine, but because they were within a traditional healthcare environment in a helicopter, but they were waiting for permission to take off, and the patient was
Mm.
deteriorating. So they had suddenly found that they couldn't offload the patient because they're on there, they were waiting to take off, and there was a complexities associated with it. But they were in the back of the helicopter, and suddenly that traditional system had become more complex because they had enough resources for the trip, but because there was a delay and the patient was deteriorating, they were having to suddenly became resource constrained because the
Mm.
patient had deteriorated. So they were having to expand their scope, be innovative, and behave as though they were in a in a complex environment or extreme medicine protocols. Even the fact that they were on a helipad within a traditional healthcare system, and so they had to diverge into that. So it's that's the I think it's more of an approach and recognition of complexities and rising complexities, and things become less complex. We can transition, especially in conflict-prone areas. You can become normal jogging. Suddenly, life becomes more complicated, and then it goes back into normal medicine.
Mm. No, and I think there's a scariness component to these environments that always adds this extra bit of complexity. Now, we've chatted about this. Well, you mentioned it before, a clinical floor and clinical ceiling. Before I'd actually chatted to you, I hadn't have thought about creating a healthcare system in this way. Can you just tell me what is a clinical floor and what is a clinical ceiling, and what are the factors that go into creating those?
Yeah, so it's a way to view systems. So imagine healthcare is a vast, expansive piece. Everything, as we said about it, is from that initial having someone go, "You're all right, mate," all the way up to advanced imagery, surgical interventions, long-term care, genetics, and all this sort of stuff. That's all part of the same picture, that same timeline. So ideally, you'd get it all. So in your ideal world, you would get all of it. And in a lot of traditional healthcare systems, if you think about a national grade healthcare system within a cutting edge part of the world, which you normally get a big chunk of that,
Mm.
and there's that full flow. However, when we're trying to build a healthcare system, normally it's to solve a problem, especially in the commercial world. Imagine the United Nations come to you and go, right, I need a block of healthcare here. And the reason we put in healthcare is to solve a tool. And if we take our mind to why we do healthcare, why do we of all of the mammals on the planet decide to invent healthcare? It's normally to solve a problem. So like, why do we do healthcare? It's like, well, because if my friend or my family gets sick and dies, it makes me sad. So I want to stop that happening. At a very base level, and then we expand it from that really. And at a very base level, it's there to stop me feeling sad that my friends and family have got sick and died. At a commercial level or at a country level, there's a part of it whereas we want people to stay at work. There might be a bit of that. Or there's a financial burden that if they get sick. So it's there to serve a tool. So normally when we get asked to build a healthcare system, they go, okay, this is the problem I want healthcare to fix. So I want to maintain my workforce, for example, in a very hard commercial level, because it costs me a lot of money to evacuate them, a lot of time off work. They're in the middle of nowhere, I want to do that. If it's a military system, I'll use a lot of political capital if my soldiers start dying, and I think that they won't fight as well if they think that there's an increased danger. I want them to have that sort of peace of mind, a very, very basic sort of peace. So you're trying to solve a problem. When they approach you as a commercial organization, you have to define what chunk of healthcare is going to be given to them. So what is it that I'm going to solve? You get that big selection, everything from URI to massive interventional radiology. Which bit of that am I going to build? So I need to take a chunk of that, and I need to know the bottom bit and the top bit. So I'm going to give you this bit. So that's how I used to define that as a clinical floor and clinical ceiling. So what is the minimum amount of care? You give me a problem I need to solve using healthcare. What is the minimum amount of care that solves that problem for you? So that's my clinical floor. So for example, if you go, right, I want to be able to work safely in this environment. Okay, well, I'll look at your risk assessment and I'll decide, okay, you're going to have lower limb injuries, there's going to be kinetic threat, there's X or Y, I want to make sure people can work in that environment. Okay, the minimum I'm going to give you is I need somebody who's aware of, be able to do an assessment with a level of kit that can do that immediate lower limb fractures, immediate life-saving interventions for sort of that 5-minute window. I'll give them CPR and this sort of stuff. That's my clinical floor to solve the problem. Now, what's the clinical ceiling is, at what point do I stop? So I'm going to give you a thing. So am I doing oncology? Am I doing chemo? Do I need radiology? Am I going full surgical? I can put it in there, but what's the point at which I say, halas, this is enough? So I might say, I will be able to, initially, my clinical floor is, I'm going to be able to assess patients on scene within 5 minutes. So I need to get a vehicle. We'll be able to stabilize lower limb fractures. I'll be able to, do initial CPR and resuscitation attempts within this patient for, 20 minutes. Okay, great. My clinical ceiling is I can't ventilate a patient. So if this patient needs ventilation, I'm not going to have that. So I'm not going to have RSI capability. I'm not going to have a ventilator. I won't be able to do surgical. So I'm not going to put in a surgery. I won't have blood. I'll have normal pain medications, but I'm not going to be able to sustain pain management. And I'm only going to have a hold capability for one non-ventilated patient for 48 hours. So then I go, okay, this is it. What that does is I've bracketed that chunk. This is the chunk of healthcare you're getting. So then when it comes to building my equipment, I know I'm not buying a ventilator, I'm not buying imagery, I don't need to hire a surgeon, an operating room. What I do know is that I need enough medicines, pain management, fluid to provide care for one patient for 48 hours, or whatever it is I said. I need splinting, so it allows me to bracket that quite significantly in it. And then it also allows me to understand the risk. I'm going to have to, if there is a requirement for surgery, that's not me. I have to look at how I'm going to outsource that. So how do I get that? If I do need a ventilated patient, how can I push that out? How do I know that I can only hold them a certain amount of time? I need an evacuation capability within that time frame to move these patients onwards. I know I'm not doing massive primary care, maybe. So I don't need antibiotics. So it allows me to understand what it is I'm building. Otherwise, it's how long's a piece of string. And also to allow the people who are taking that in, say if you're buying it or you're utilizing it, understanding where their risk lies, understanding what they're buying. It's a product. Healthcare is a product, and understanding how I'm solving that solution. Now,
so from a practical perspective, say you hire a mining company and you have a mine that is being dug up. You can see I'm
Yeah.
not a miner, but they're starting a mine somewhere really remote. Where do you start with creating or coming up with that clinical ceiling and clinical floor? Is it the patients that you want to or potentially will see? Is it logistics issues? Uh,
It's
how do you go about practically deciding those things?
risk. So what risk are they trying to avoid? So this, it all starts with the risk assessment. So in a real commercial setting, that's where, even the military setting is like, okay, what are the risks the population group is facing, and what are they willing to accept, and what are they willing to not accept? So with a mine, you'd be looking at, for industrial incidents and that sort of, okay, we've got a high risk. Okay, so we could probably do something about that. You know, mine collapse, gases, all that sort of stuff. So we start building it across that. And a lot of it comes from that risk as what's happening in a conflict environment. Is okay, where are the risks? What we're facing because there's a penetrating injury threat. Okay, so we probably need surgery to try and mitigate that. And we need that within X amount of time, which does your positioning and capability and all that stuff. So most of it starts with the risk assessment and understanding the problem you're trying to fix. Where it gets interesting is in the population health. So when we're looking at trauma and all that A&E stuff, and the acute stuff is normally quite easy because it's sort of quite sort of standard. The piece is, do they want to do primary care? Do you want to do broken arms and cold and flu? Do they want to sit that? There's a lot of logic to that because you say, look, I can stop them taking days off work. The guys are going to get sick, and I think that's generally sort of accepted. Do I want to do chronic conditions? So am I in charge of pre-existing hypertension? They hold a risk that if my population is slightly sick, and then they go, look, you can do it. If someone's turned up with hypertension, I can put someone in there and put capabilities to manage that, as their primary carer, but it's up to you. Or you screen before they arrive in there. So they said, we pre-screen all our people. If someone presents with that, it's been undeclared and they're off. We're not willing to sit that risk. And so you work in conjunction with them. The acute stuff is normally quite easy. It's normally into that, how much do you take ownership within private sector of stuff that would normally be national sort of their general practitioner. When you're dealing with nation states outside of that sort of deployed environment, it is slightly different because then maybe you do want to own that. And therefore your clinical ceiling increases away from that first 4 days. So anything you can't manage within 4 days, basically you send out. And then when you're actually dealing with a nation state and you're developing a national health system, it's a vastly increase because you're looking at lifetime. And even then you've got to think about, okay, what can't I do? And then you talk about the financial implications, and then your limiting factor when you're dealing with more of a nation state might be financial. I have this amount of money. How can I get the best value per dollar for healthcare for everybody out of it? And that's that health economics piece. So for me, it's what it is they want to achieve. What is the purpose of healthcare? Because they don't have to have any. You just, step over bodies if you wanted to, like ethically, yeah, and legally. But in theory, that is possible. How much ownership of healthcare do you want to do? Do you want to do the minimum? Do you want to do the maximum? A lot of that is risk and intent of what problem it is you're trying to solve. Healthcare, delivery of healthcare in remote environments is trying to solve problems. Logistics constraints, that's a problem for us to solve.
So, how much does the financial aspect play in this when you are planning these systems?
Yeah, well, it's part of the problem. So it's part of the complexity, So that's part of being in a complex environment. It's a financial constraint. So we could say, so, and there might be the real bits. It's like, okay, I want you to look at stroke victims. Okay, how much? I can look at a stroke victim, or I can look at a cardiac, and okay, but I've only got this amount of money. Okay, do you want me to do interventional cardiology? I can. Well, I can, but it's going to cost you this amount of money. Like it's within the remit. So when you're talking about looking, I want you to be able to manage a cardiac patient. Okay, what it's the same as it's like the ceiling, isn't it? Like I'm saying, within those patient groups is looking at, okay, what's my minimum piece? It's recognition of cardiac illness, resuscitation, so early recognition, rescue elevation in the patient, resuscitation protocols. Now, when it comes to revascularization and reperfusion, I've got options. So best praise is PCI, so primary PCI. But in order to achieve that, I need generators, I need people, I need this sort of bit, or I can thrombolize. It's not as good, but this is it, or not even that.
Or
And
aspirin.
yeah, exactly. So that's which bit of that do you want me to do? And that's often the complexity of limitations. And they're going, and that might be, and again, I've seen it. People can do that in remote environments because you say, okay, look, the risk is if I'm 1 hour away from a center that can do PCI, how does that sit in my risk assessment versus, and this is why I come into it and I do my hospital assessments and stuff like that, and look at, okay, what capabilities you have versus, the closest one is 4 days away. Okay, well, you're going to sit with a risk. This patient could benefit from, he's not a thrombolytic patient because he's had an operation, whatever. He could benefit from that, but the reality is that the limitation of it is I can get him there, but it's going to be in 4 days' time, and I can transport them. And that's that understanding, and that's where the financial constraints come into it. They are real, and maybe you can get that. You can spend all your money. You've got a box of money. You spend it all on interventional cardiology, but then there's another patient you haven't seen. There's a dialysis patient, or there's another. You know what I mean? Like it is, and that comes into it. It's very, very hard decisions because that's where we get into who are you not seeing, and it's doing the most for all. Like, where am I better off spending my coin? Someone's going to lose out, and that's that clinical ceiling.
When you are creating the systems, do you normally start with the budget and the projects that you've had? Do you normally start with the budget and then work backwards? Or do you normally start with the amount of procedures and interventions that you want to give and then give the budget for it?
I normally start with the problem. So what is it I'm trying to solve? You know what I mean? It's kind of thing. What are the problems I'm trying to solve? And defining that. It's like everything. It's like when you get into doing innovation and these sort of things. Start with the clearer understanding of the problem you're trying to solve, the clearer the approach is, and it's where's the pain point that I'm trying to help with this. Is it a full sort of shebang and stuff like that? Understanding context as well. So really understand your context of your environment, be it political, logistical, temporal, geographical, environmental, all of those complexities to move in. So when you understand the problem, understand the constraints and complexities, and then you approach it and go, okay, how do I solve this problem in this environment? And then you get into the clinical bit. The clinical bit's relatively easy because that's done for you.
Yeah, I think there's so many ethical considerations that you have to have when you are making these decisions. How do you go about deciding when you're creating a system from an ethical standpoint, you are which procedures you're going to do, which patient populations you're going to be able to treat? How do you go about doing that ethically?
So I think there's a separation between ethical. It's a lot simpler at a provider position. So I've made ethical decisions where a lot of it is about access to healthcare. I've certainly been in situations where, as a provider context, where someone, it might be we've got healthcare put in for expatriate populations and we're working in a local environment, and then you get presented with somebody who wouldn't necessarily meet the criteria, but it's easy to fix, and you'll probably go and do it. So that's an individual ethical sort of piece. My personal position, there should be a base of healthcare for everybody. I buy into that. When we're talking about in broader systems base, it becomes far more complicated. One, whose ethics? So we talk about ethics as though it is a law of nature, that it could be like gravity, you drop it anywhere in the world thing. But is it the ethics of the financier? Is it the ethics of the provider? Is it the ethics of the people you're treating? Is it the ethics? Whose ethics? So, and that's where it becomes quite complicated in approach. So I think the key is in the fairest situations is when everyone loses out equally. If everyone is suitably unhappy, effectively. You think about even with the
Yeah,
kids. You know what I mean? Like I've got
yeah,
two kids. Generally, the situation is fair enough when both of them are sort of unhappy at an equal amount. It's the sort of way you do it. But there's transparency.
yeah,
So none of you are getting the toy because both of you are arguing about it. Similarly with the healthcare, I think that some people lose out. Someone, as I said, there's a ceiling of care. Eventually, someone will lose out. I think the key is making sure that it's not one section loses out over more than the other one. So I think that's when the ethical healthcare comes into it, is that healthcare, it can be achieved, that decisions are made broadly and clinically. That being said, if somebody is providing, so in these environments, so a whatever company is providing, the problem they're trying to solve is to keep their expatriate workforce at work, or the United Nations are trying to look after their staff and these pieces, they're spending money on trying to solve this problem. There's donor countries donating for a purpose or whatever it is, or be it shareholders, and there's the money aspect. Is it ethical to spend their money in ways that they didn't want it to be spent as well?
Mm.
So it's a there's a lot at system at an individual level. You can hold your own ethical boundaries, and most healthcare providers generally align on where we think is sort of the general rights and wrongs of things. When it's systems, there's that many stakeholders. It is a very much more complex navigation.
It's so much easier as a practitioner or
Yeah,
clinician when you have certain things. You have your patient in front of you, you have the equipment that you've got, you have got the, well, at least from the pre-hospital perspective, you've got a certain distance, you've got procedures that you can do. So all of those things are clearly defined. You now make the best decision that you can, or the most ethical decision with all of those constraints. It's the ethics come into it in a much more different way when you're having to decide what patient populations get which certain procedures, what's available. And I think that's much more challenging.
yeah, yeah, it is. And at what point your clinical ceiling happens? Yeah, and particularly it's what clinical ceiling is so difficult as healthcare providers, and it's very cultural. We always want to fix things. We always
Mm,
want to fix things, and I've seen this, and where we can't fix it, or we can, we just don't have that capability. And we view that as a real failure. Oh, if I had this, I could fix it. It's like, that's not the reality we live in. Like, it's very, very difficult. Like, if we had this thing, we could fix it. Okay, let's buy that thing in. It doesn't, and it's really hard. It's like, well, we could do, there is the capability. I know how we can do it. We just don't have it, and we can't get it.
mm,
And, it's very, very hard for providers to do that. But at a systems level, that's the unfortunate reality, is that there will be a ceiling at some point,
mm,
where that is no longer able to be done. And I think that as long as why I view it ethically is to ensure that that ceiling is based on values that a decision making, that
mm,
doesn't that is fair. I think that's the key. There should be no patient group, and however you define a patient group, that is unduly served with less than the others. I think that's
mm,
sort of the best way you can do it. If everybody loses out equally, and again, similarly, when we're looking at the financial model, is targeting and oversupplying one group really, really well, and you're saving lots of these people. Is that ethical when it's done at the expense of another clinical group? Because
mm,
you've only got the one token to spend.
mm. So you just started your career quite a few years ago. Um,
What are you saying, mate?
and I should have, maybe I'll rephrase that. You've had
No, yeah, 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 I
you
feel that.
experience your experience, and I mean, even when I started my career, there's certain interventions that I'd learned about, that we don't do anymore, or that we've changed our approach to. But um, what interventions or what innovations do you think we're going to see in the future that will make healthcare more accessible, especially in the remote environment?
I think certainly the digitization, so digital care, I think is going to be. I mean, you can't avoid it. So previously, limiting factor is like the biggest problem that we used to have, or generally in getting care in remote environments, is people. It's trying to get people next. Every healthcare problem is a logistic problem. All
Mm,
everything. Be if you collapse, if your gran falls over in her house, it's a logistics problem. We all know the quicker the level of assessment done on you, the better the outcome. I think it's a generalization that I think holds true across effectively everything. The first contact point, be it cold and flu to stroke to car crashes, the
Mm,
quicker you can move the first contact point to a healthcare decision maker or something, an educated hand, the better the outcome.
mm.
Might be
And
minor,
how
but
quickly does that person make that decision in order to get
yeah.
care? Because
So
it's not always get on the line. You might have a minor, or you
yeah,
might have a worker that doesn't want to come into the clinic because they're worried about
yeah.
taking sick days and not getting paid for those days. So,
Yeah, so there's all of that sort of stuff comes into it. So I think technology, if you're looking into the really remote environments in the Bondi, where certainly I've been in places where the towns don't have names, they've got numbers, it's horse access only, and things like there's this general limitation to sort of care, like geographic and all this sort of stuff, limitation care. I think digital enables to put care far further forward because you're not looking at human support. It is easier to manage electricity and data than it is visas, life support, hotels,
mm,
accommodation. Like it generally is, to a certain extent. And even though it won't be necessarily as good as a human, it's certainly better than nothing. So I think the digital capability, if you have a mobile phone in these areas, we've permeated it. You've got logistics change that allows Coca-Cola to get everywhere. You can combine those two aspects to create a healthcare network where you can put that first assessment in the palm of every human is a reality.
mm,
Now, is it a human doing this? No. But is it an initial screening decision making? Yes. Certainly, I've been in environments. I was working in Tanzania. It used to take parents 4 or 5 days to get their children to the nearest healthcare provider.
mm.
So when you're dealing with a septic child, it's
The nearest healthcare facility, not
no, no, yeah, yeah. No,
definitive
it's not the
care, just
definitive care.
a
That's it.
primary care
It's
clinic.
because
Yeah.
it's by foot.
Mm,
And that's it. And maybe they skirt by a nurse on the way, but they don't have treatment capability.
mm,
So imagine being able to put a News 2 in their hands and going, okay, like you need to get these kids moving now. So you're solving that because you're making decision making earlier. It's one of the biggest clinical points that I learned. Certainly, it's sort of defined my practice. Certainly, in my early career, was under because I couldn't do anything about a lot of stuff. You got a cold, I'll give you some antibiotics, or you got an infection or something like that. Most stuff I couldn't do anything about, just because
mm,
that's my ceiling of care was anything I couldn't fit in a bag.
mm,
Really, that's it, and it's quite a complex condition. So I could do diagnostics, but that was sort of it to a level. And I soon realised that the key to a good remote healthcare practice is early decision making. Is getting really good at a physical exam, and making a decision making early, understanding the risks, and starting the process of evacuation or movement towards higher level healthcare early. Because if it comes to the point at which they would need traditional healthcare within the environments I was working, it was too late. Because it would take me 3 or 4 days to get them to where they need to go. So I think that when you're looking at digital assessments, I think with AI, those sort of interactions that are language agnostic, that are culturally agnostic, that can take that data set from an individual, from a patient, from an unskilled provider, and help make early movement decisions, I think that will be huge because you can start those journeys earlier.
mm,
Just and you allow that initial point of contact to be a lot earlier, and that's reliant on technology that already exists. So I think
mm,
digital, I think, is going to be massive, and decentralization of healthcare. For me, our healthcare is built around big pocket of healthcare and hospital, lots and lots of stuff, and outside of it, barren wasteland. The odd little
mm,
doctor's office, but all our healthcare lives in this defined building.
mm,
Outside of it, car park, nothing.
mm,
Literally 2 meters outside of healthcare, nothing. That's a hospital, barren wasteland of healthcare. Inside, more than you throw a rock, you'll hit healthcare. It's
mm,
crazy. Yeah, our population doesn't live like that. We live everywhere. There's loads of people everywhere, but healthcare is pocketed in these centres of gravity all around the
mm,
place. And I think that digitalization will allow us to break down those walls and move healthcare, allow it to flow out into the actual world to align with everything else. Grocery shops are everywhere. I can get petrol everywhere. You know what I mean? There's more car shops than hospitals. Mad.
mm.
So I think that digitalization will allow that to flow, particularly in remote and rural environments. I think that'll be the fundamental key is how we leverage that.
And I think that reminds me of a project that we're working on now with watches and monitoring of patients outside just during the everyday. And with these watches that are becoming more and more complex, I think I don't know the exact technology now, but the new Apple Watch can check if you've got AFib.
Yeah.
For our non-medical people, that's where your heart rate is not regular. And that's obviously related to stroke risk. So you can pick up these things so much faster if you've got someone that's wearing a digital device all the
This
time.
is my I was chatting to nurses a while ago and a bunch of A&E, and my big, but we have all this, but healthcare's avoiding it. So you get hit by a bus, you go into A&E, you've been wearing a watch that has got your entire vital signs monitored from pre-impact. And what do we do with it? We cut it off, put it in a bag, and give it back to you if you survive.
Yeah,
You know,
yeah,
you've literally got on-site monitoring on these patients, but our current healthcare systems ignore it.
yeah,
Completely ignore the fact that patients have got more monitoring. So in a ward, you get monitored every 6 hours, 4 to 6 hours. You know, whereas our patients walking around outside without outside that box of healthcare are getting monitored every second.
yeah,
You know what I mean? Like it seems so. It's been a really interesting digitization. Is that our patients walking around are getting monitored with their vital signs more regularly, exponentially than our people in hospital. So, but we ignore that fact. It's crazy. So there's been a really interesting revolution where the care achievable by the non outside of those blocks of hospital in certain areas is exceeding what's achieved in hospital. Yet we haven't joined those dots on it.
yeah,
And when we invite people into the hospital because they're feeling unwell, we don't scan their monitoring devices. We sit there and go, "Ooh,
yeah,
you've got a like, yeah." I could literally look at it. I've got the past week's history of my whatever on my watch. You know,
yeah,
so I think that there's a lack of acceptance or a lack of integration between the commercial aspect and there's a level of snobbery is the wrong word, but it's not a medical device. Therefore, yeah, it's not. But you know, we also know that we don't do things perfect in hospital. I would trust a Garmin's respiratory rate over 12.
yeah,
You do mean so? I think we have to then open the doors a little bit and integration of digital systems within our general healthcare services. But I do think the particular impact will be found going. Is it perfect? No, but going 0 to 1, I think is fundamentally more impactful than going from like 95 to 98.
yeah.
So I think that's going to be the big revolution evolution of healthcare, both in traditional settings and in more robust, complex environments, especially at population level.
And that information is clinically relevant. If someone's heart rate is normally 50, when they come into your clinic, you don't know that. And
Yeah.
so many times when we are making decisions about patients, we're deciding or looking at the average, deciding how normal that is for that patient, and then making a clinical decision on the law of averages. But if we had the average blood pressure of the patient, and the patient comes in and it's sky high from that or much lower, even though it's outside of normal range,
Yeah.
what the normal population is, we can now make a much better informed decision because we know what the normal is as opposed to just guessing on what the
Yeah.
average.
Well, imagine your Garmin printout of someone who's been in a car accident. So imagine you'd visualize that for conditions. It will peak up because they're super scared and the heart rate goes tacky, and then gradually because they've calmed down a bit, pain management, it goes down. But then gradually you see it start creeping up. So it's still within normal
Mm,
bounds, but you've seen it over the past
mm,
hour start creeping up. The respiration rate went high and it's normalized, and now that's sort of creeping up. And what it's
mm,
giving us, I was very lucky to have very good mentors early in my career through various reasons. One of them was a senior anaesthetist, and his chat used to was, "I'm interested in the movie, not the Polaroid." I don't
mm.
want, and what we're doing is in current healthcare, we tend to, just because we are limited, because you can't have someone watching them all the time. We can't rig you up all the time. So what I'm getting is a series of Polaroids and making a stop motion animation of the patient's physiology. With technology, what it's enabled me is to make a HD movie of it. So that for me is where it's a force multiplier. It's doing what I can do. I can afford, because I've got financial constraints, I've got logistical constraints. I can afford to have an oversight on your vital signs 24 hours a day.
Absolutely. You can make much better informed decisions
Yeah.
with all the information.
Yeah.
So we have a closing tradition on this podcast where we ask the guest a question that they haven't seen before. So your question is, what ethical principles do you use when deciding to evacuate, treat, or leave behind patients in extreme environments?
I think it comes into, if you've done your planning well, it's not an ethical decision. Do you know what I mean? I think generally that's the entire purpose of planning and looking at the clinical ceilings and things like that. It's not as, can I, have I been scaled when I've done my scaling to take a ventilated patient?
Mm,
Yes. Okay. Then for how long? You know. So then if I can tube and ventilate a patient, and I know that my entire scaling is at X, I can take them for 72 hours or whatever, as I've said. I know 100% I need to get that ball rolling. I need to go, and my
mm,
systems should have been put in place where I've tested my evacuation protocols so that I know the routes and methodologies by which I will remove that patient in a ventilated state within 72 hours of them presenting. That, if I can't do that, then my planning's failed.
mm,
Yeah, effectively. So that's the point of sort of good planning. So evacuation should be very clear, and this is where clinically I like having a clear ceiling because it allows me to make, if there's a chance of this person, even if they're not ventilated, for example, and I can't, if there's a chance of this person breaching my ceiling, I can make the decision, why are you going to spend treasure on getting a helicopter or a fixed wing for them, is because I think there's a risk that they'll breach my clinical ceiling within the next 48 hours and I want to get them out of here before then.
mm,
So I would always default in evacuation, you know,
mm,
for that sort of pieces. For patients who that I can keep, I think that there is, again, planning. So do they fit the criteria and the profile of what I have been designed to do? If yes, good. If no, why not? Recognize it because my delivery didn't arrive with whatever drugs. Okay, then let's accept that and go. Okay, this is an issue. We need to do something about it. But I think there's also a level of clinical gestalt that comes into it. Is, you know what I mean? How is this patient looking? Not now, but in 2 days' time. And
mm,
certainly, I've made that decision where I was off Nigeria on a vessel, and we were 3.5, 4 days to getting close to port. So we were off in the Gulf of Guinea, and so that the only port was, that was where you could get healthcare. That's where healthcare lived. And I had a patient present, LD patient present with a history of vomiting. ECG was good. There's a bit of blood in his vomit, and he just looked a bit, peaky. And I was like, right, he's all
mm,
right now, but what's he going to be like? There was a very unspecific abdomen pain, one of
mm,
those, like, he could be absolutely. He was over 60, and I was like, right. I'm not thinking, could I handle him then? Yeah, he could go to bed, a cup of paracetamol and a glass of water, and we'll keep an eye on him. But what was he going to be like in 3 or 4 days' time? Like,
mm,
there's a clinical pathway that exists where that could have been a bad outcome. So you could see how that clinical pathway could thread itself. There's a route, and that's why I visualize it like a route that exists. There's something's going on here. I've got no imagery, no ultrasound. You know, it's generally all right. But then I said, right, I want to move this guy. $1 million a day. So we lost. So it's about $1 million a day to shift this vessel off tasking to move him to port.
mm,
So I made that shout. I was like, look, this is it. I think there's a pathway. I'm uncertain. Now he ended up being fine. So it cost $6 million because the guy had a tummy ache.
mm,
But I'd stand by that. I'd prefer to do that than other outcomes. As luckily, it's never happened to me. Where there's another event early in my career where there was an individual present, not on my boat, but it was in a broader sort of context where I was sort of working, where there was an individual presented to the medic. They had 2 days to finish whatever job they were on, and he sent him to bed. Basically, he had a bad case, bad high temperature, a bit of the flu. It wasn't pre-COVID times. This is about 20 years ago,
mm,
and he ended up dying on the vessel
mm,
in his cabin. You know, because and his presentation was not particularly nefarious in nature, but there was probably a pathway. Now, I don't know what I would have done. I don't know what any of us. You can never second guess and things like that. But that there was that presentation was sort of there. There was a route to the end. There was a hint that something could happen, and so that decision was made not to evacuate. In that case, now was that ethical? Was it bad? I don't think it was an ethical issue, but I do think there was, like, would you have gone to the doctor for it if you were at home? Probably yes. Was there an impact that maybe there was pressure put on because they only had a day and a half or 2 days left to finish this thing, and it would have really, really had a large impact, operational, financial, all that sort of impact? Probably yes. Now, was the medic involved pushing hard and got overruled? Don't know. I imagine they would be pushing it. I'd like to think they would be pushing it, but kind of getting, those sort of pieces. So I think ethically there. Another one I've heard of was, again, happened to me with one of my friends, my colleagues. So movies and films. It's happened a couple of times actually that I've heard of, where it makes all these adventure programs. It makes good TV if someone gets a little bit sick. There's a bit of drama, and this particular one there's two of them. One of them you'll be able to know what it was about, so I won't say it. But one of them, this one was doing high altitude, and one of the contestants for a better stage started showing early altitude symptoms of early altitude illness, sort of normal sort of stuff. Discussion was had, need to get him down or her down, and there was an argument with the producers to go, okay, well, what's going to happen? Well, they're gradually going to stumbly mumbly, and this is the pathway. So effectively, early onset, high altitude headache, early signs, SATs low, simple, altitude catches you up. So you get them down before it catches up to where they are. But there was a bit of a discussion. The patient did get moved down eventually, but there was a discussion about, okay, well, can we keep them and video it because we can put some cool music on it, and then then you get them down then. So you know what I mean? I think on the provider level, ethical things when it comes to evacuation and moving. Within my practice, I've been lucky that what I've done. Within my systems, we've generally been quite lucky in identifying, because I do think we spend a lot of time in understanding and the clinical ceilings. What we can and can't do. And this is why it's really, really important, because otherwise you can kid yourself. And it's a non-ethical decision. It just is what it is. They meet that criteria. Breach, risk of breach, gone, easy. Happiness, stay. But within more worlds, I have heard of things where there is that provider level ethical issues going on. So where you have to fight your fight as a clinician. It does help if you have clear criteria though, because it makes it, when you're having discussions about it and you're going to spend treasure, it's really useful if there is make it black and white, so you remove the ethical argument from it. It is just the way it is, and I think that falls into healthcare, looking at early warning scores and all this sort of stuff, and admission criteria. When do you admit? It's no difference to when you admit to ICU, when you admit to surgery, when you extubate, when you downgrade from ICU into ward. There's always a slight gamble and risk, but what we've done within healthcare is make it not on the one person. It is there's broader criteria, admission criteria. Okay, this person gets ICU money spent on them. So I don't think it is, again, we can dress it up as a slightly different thing, but it does fall into the general practice of healthcare. And this might, going back to our initial start, whereas these environments, it's still healthcare. The principles of healthcare still do it. It's just slightly different complexities.
Yeah. Have you ever had a case where you've had to leave a patient behind?
No. I mean, if you're talking mass casualties and stuff, we've had people who we've all had people who have been dead, and where we've either called it dead or, certainly I've had cases where I haven't initiated care because there's clear cause. I've got exposed brain tissue,
But that decision's easier.
Yeah.
The decision where you're saying, okay, well, this is not clinically viable.
I think there's been patients who have within systems, as there would be in any system, where there is a pathway to do something about them, but we it's not a reality in which we live in. Where if they were in another environment, could there be an improved outcome? Yes, but we're not in that environment, and it can be a discussion afterwards. Do we want to integrate that pathway into our environment or do we not? Is it? But this is where that planning comes into it. Is it optimal care? No. Was it within our planning to deal with these? No.
I think there's, if you go to a mass casualty bus accident, there's a whole bunch of people
Yeah.
in the bus, and you're making decisions, you're triaging. That's a bit different to the decision if you are on Everest and you've got to
Yeah.
decide to, move that patient down. What are the risks of doing that? Are you risking other people?
Yeah, I mean, I've been in a
I
situation
think
where it's
that's
too risky. I think that's again different, where there might be the off chance you could do something, but because particularly if there's a kinetic threat that is that you can't it's at a distance or whatever like that. It's effectively if it's over there, there's nothing that I can really do. In the reality of it, and you've also got to think about sometimes the everybody else. So, even on expeditions. So I've certainly been in places where it's a decision point about, okay, do I go with the patient? There's always one. So it's certainly be situations where if you're trying to evacuate someone and you're looking at going, right, and decision point, and you don't have, you're the highest grade provider on site. And what I would always encourage is a lot of within remote healthcare is training and building capability because it helps you out a lot, even at mid level. So I need to evacuate person A because they have some sort of condition. Okay, ground's not a problem. But there's a timeline for them to be evacuated. It's going to take X amount of hours. I'm the only provider on site, and I've got another 300, 400 people on site for this timeline. Do I go with that person and provide better care for them en route, where there is a risk? Because normally when you people always forget that when you transport, there's a risk because you don't have even in a limited clinic. Sometimes I've made that decision where actually I can't go with the patient, particularly a cardiac patient, because I will leave everybody else exposed. And the world continues. What happens to the next cardiac patient? I'm not there. And they do need to go somewhere, perhaps, ideally. But if I don't go with them, they don't receive any care for 8 hours. So,
yeah,
so yes, the destination where I want to get them, they need to get the destination, but the logistical requirements of getting there mean that they're in a care deficit for 8 hours. Now, I don't know if they're stable enough to do that. So I'm stuck with a moral, okay, they need to get there within 8 hours. They need to get there. But I also can't leave 300 people without care. So in those
yeah,
situations, maybe I deliberately don't move them. I hold them slightly longer, even though I know that I need to get them somewhere because I need them to be more stable to go with a lesser grade of care to wherever they're going to try and get to because I can't. And that's juggling. You've got to think that
yeah,
holistic sort of position, Or sometimes I might go, right, we'll pause operations, might be another way to do it. So I want to reduce the risk. That's another discussion I've had with people. Let's not do whatever it is we're trying to do because we've got a decreased capability because these assets are no longer here. So I want you to stop doing high risk operations, and this happens in military as well, for this period because our med unit's gone grey. We're not gone dark, but we've gone grey. We've got a minimum requirement because we're dealing with something else. And
yeah,
so that's that where you have to play that game, and that's those considerations, and that's their complex.
yeah,
You need to approach them with a bit of awareness, and like everybody loses out. It's just making sure that it's done overtly and fairly, you know. So those situations, yeah, that's not uncommon.
yeah. I used to work at just odd locum shifts on the side of horse jumping,
Yeah,
um, and one of the riders fell over and hit her head, um, and we used to take an ambulance to sit on the side of the
yeah,
horse racing track, and our patient came in. She was sitting down in the ambulance, and I said, "Okay, well, now we need to phone for an ambulance to come to pick up the patient." And the family members and the friends were quite up in arms about the fact that we've got an ambulance here and we can't move her with the ambulance. And that was quite a difficult situation
yeah.
to explain to them that we can't move because we have to stay here for the rest of the competitors and we can't just move off. So I think that's just a little
exactly.
snippet of
Yeah,
what can happen in remote sites when the distances are so much
yeah.
bigger and help is not
Yeah, and
at
you
the
were.
ready.
So this is how I was saying beforehand. Even though you were, I'd imagine you were in a reasonably well-run healthcare system. You worweren't in
Yeah,
a extreme environment.
half an
However,
hour from hospital.
yeah.
You know,
So, but the situation became complex. It became a complex environment because you were resource limited. Because you had 300 possible patients and one real patient and one ambulance, and then you're having to make complex logistical decisions. So that's you know what I mean. That's how it can shift. Is that, and this is why I think there's a lot of crossover and learnings within the deliberately sort of complex extreme environment medicine can also, you know what I mean. It's a very much more deliberate approach to considerations that also impact traditional healthcare systems. I think there's a lot of
absolutely.
this world of this exists and this is that there is a lot of cross. It's an extension of the same thing. It's just there's more focus on the complexities and the limitations in these environments, and like care rationing, it has to be a consideration. I had a piece there recently where we were the extended logistics chain, and we're running out of vasopressors. And it takes us time to try and get it. We had a big load of patients come in that were all intubated and we required support. But then we're looking at, okay, who needs the most?
Now
You've
you
got,
need to make the decision. I'm going to tone down
yeah, like
the
who can
infusion on this
tolerate, yeah,
patient. You know,
yeah, yeah,
yeah.
and that's the reality of it because what can you do? And that's because suddenly, and it takes time to get things in. Like remote medicine is mostly logistics. Is looking at these sort of pieces, and that's when you're doing your planning. I always say to my like planning is like people, stuff, and place. You need to invest in all of those things, and it's the way they all work together. You can have really, really super duper people, highly skilled, but if you don't have kit and you don't have a place for them to do it in, it's useless. You can have an amazing facility, but an amazing kit, but you don't have people to use it. That's a skill set. So all of that has got to be invested in, and I think that's when you're looking at how you spend your treasure. There's a lot of assumption. If I spend a load of money on clinicians, that's gonna be great. Or a lot of times I spend a load of money on on equipment, great, but no one knows how to use it or implement it. And I've seen that a lot with donor agencies. It's quite I was in Tanzania when the hospital's doing an assessment. They were spending 10 million on a new ICU ward. I went in looking around, and I was sort of like, really lovely people, great, you're doing amazing work. I said, where are all the machines that go ping? And they had one ECG, a trolley ECG, that they rolled out, and that was it across the regional hospital. And they hadn't been exposed to, this hadn't been one part of their education because it wasn't something they'd used hands-on. They'd used it a couple of bits in training, but never. So if you give them a huge ICU unit, like you didn't have this, you needed to invest in the skill set as well as the kit. If you bought half the kit, spent 5 million on the kit, 5 million on investing in the education to get people to use the kit, brilliant. But just here you go, here's a load of money, buy a load of machines. Doesn't work.
Yeah.
You know?
Yeah, healthcare is actually like a wheel with lots of spokes, and each
Yeah.
one of those spokes needs to be working in order for the wheel to
Yeah,
keep moving.
yeah, and it's disinvesting in all of those areas, and it might be deliberately withholding. This is where it comes into systems development. I'm deliberately withholding from buying that new piece of equipment because instead I'm investing in the power supply for the hospital because the power keeps going out. You know what I mean? Like, so it's a lot of that, and as long, and this is where we get the ethics of it. Is like, where am I spending my treasure?
Nick, thank you so much for your time and coming on the podcast. It's really been great. I could carry on chatting.
Yeah,
with
have
you
a chat
for hours, but
afterwards. Yeah, get a coffee.
Thanks so much, and I really appreciate it.
Yeah,
Thank you
super.
for coming on.
Absolute pleasure. Enjoyed it.